Well, welcome everybody. Welcome everybody to this webcast of the USTMA Consortium. First of all, I'm Spiro Cadland. I'm a hematologist here at the Ohio State University, but this is just being broadcast from Ohio State. This is really a production of the USTMA and a result of the efforts of a lot of people. First and certainly not least is Claire Messick, who you've all been communicating with, or many of you have been communicating with via the USTMA Consortium site to get answers to your questions. It was really her idea to get something going for patients with TTP to really kind of address a lot of these questions that have been coming up. You're just seeing me. This is just a spur of the moment, get this thing going, but we're going to have investigators from our consortium from around the country that are going to be participating via Claire, kind of texting in their answers, doing as best we can on short notice. So we have Dr. George at Oklahoma City, at the University of Oklahoma, who will be participating as well. Marshall Mazeppa at the University of Minnesota in the north. In the east, we've got Shruti Chaturvedi, who will be participating as well. They're online, they're going to be answering questions, and periodically I'll throw things to them and we'll give them some time to respond. So I think the first question we'll start with, I think that's been asked a lot, is are patients with TTP more likely to get an infection with coronavirus? And the straightforward answer is no. There's nothing about a TTP patient in remission that places you at greater risk for getting the virus. So the same precautions that are being told to the average citizen really apply to you as well. There are certainly some caveats in that patients who might be on immunosuppressive medications for any reason. But in our world of TTP, it could be prednisone. If you're recovering from an acute episode and still on some prednisone, that might place you at a greater risk of infection. And we'll talk a little bit more about Rituximab. It's not really clear if there's a marked increase in risk for viral infections. It's not very clear if there's an absolute increased risk of infections in any patients with TTP with Rituximab, let alone specifically viral infections, but there certainly has to be some caution, as when you're closer to your treatment with Rituximab, you're going to have lower lymphocyte levels. There is a risk for viral reactivation, we say, for previous viral diseases that were treated and your body has suppressed. So I think although the risk may not be tremendous, we still need to be careful in thinking about that and answering questions. This is an open forum, online obviously, and the questions that you can see right here on the slide, admin@ustmaconsortium.com. Email the questions or text them to Claire Messick, who's helped put all this together again, whose brainchild this really was, and she will get them passed on to me, and I may forward them out to my colleagues around the country that are participating as well. While everyone gets these questions written in, we'll start out with a couple of the questions that have been, we've got a good list of questions already, so it makes sense maybe to start with that. And that may answer some questions that you already have. So these have been questions that have been sent in the last sort of day or two as we've led up to this. So the first question is a good one. Have you heard any cases of TTP patients contracting the coronavirus, and do they do better or worse? So there are no known cases of coronavirus in patients with TTP, whether it's acute or in remission. The reporting might be a bit delayed. But the investigators throughout the world, led by Paul Capo in France, and multiple other investigators have sort of gotten the word out. There's a form that has been circulated amongst investigators around the world in order to collect information from any TTP patients who might develop a coronavirus infection to try to collectively learn more. It's obviously a pretty big world, but it gets a bit smaller within this disease. And the group of investigators around the world are very collegial. We all work together regularly, and we're sharing resources and experiences now to try to learn more about how to help patients with TTP who may get a coronavirus infection. Another common question is, what about masks? Homemade masks, should we be wearing them? And in general, if you listen to the authorities and the medical experts and those that really know a lot about these infections and the epidemiologists, they'll tell you that the masks are really important for those who are infected to prevent the spread, these droplets that people can touch, and then they can touch their own eyes, mucous membranes, and develop the infection. So the masks are really important for those who have an infection. If you have the infection, obviously, or you're suspected, you should be isolating yourself. And this social isolation is obviously the main thing that we have. When cases, you have to go out, be very careful in terms of hand washing and general precautions. But in general, should masks be worn by patients with TTP? No, they shouldn't. And again, follow those guidelines that you're given by local authorities as well. Another question that's come up a lot is there a possibility that coronavirus, like other viruses, may cause TTP, particularly those with a history of it? Can it trigger a relapse? And in general, the answer is, it's a complicated answer, but in general, the answer is going to be no. The viral infection is not going to cause TTP. But one thing that we do know, and that people who may be at risk for a relapse, and it may be when you have lower ADAM-TS13 activities. If you have a lower ADAM-TS13 activity, we talk about the second hit that can occur. It may be an infection, rarely maybe it's a medication, a surgery. Any sort of stress on your body could be that second hit that leads to the developing of a TTP episode. So would the virus directly cause TTP? The answer is no. But in the right situation, in the patient who may be at risk, it could be the trigger that does it in some patients. So another question we've heard a few times, is there a concern for those who aren't on corticosteroids or any other immune suppressants, or patients with other complications of TTP that we've talked about before? And the answer is no. Again, just like anybody else, common sense measures, it's the isolation, it's the hand washing, the avoiding of people who are infected, and the people who are at greatest risk, those with comorbid medical conditions, which doesn't necessarily mean TTP patients. It's cardiovascular disease, hypertension, being extra careful to isolate yourself. But the caution really is those who have or are on immune suppressive treatments. Another question that's come up frequently is, again, it's hard to answer directly or accurately at this point, is the Rituximab, and what's the role of Rituximab? And I think in general, we don't know the absolute answer. There is some concern for some viral infections, possibly CMV, some other rare viruses, or the reactivation of previous viral infections that have been controlled by your body. The Rituximab can sort of uncover that risk. So the answer is we just don't know, but the same rules apply, the isolation of yourselves from others, the social isolation, avoiding those who are sick, and the hand washing. If you're in the very earliest stage of having received Rituximab, we certainly might say be a bit extra careful. The thought is maybe in the first 9 or 12 months is when the lymphocyte levels may not have yet regenerated and come back. So there may be an increased risk, but again, nothing specific that we know, nothing that should really change what you should do outside of these normal and already existing recommendations. Another question that's come up several times prior to this coronavirus outbreak that I think is very important to emphasize the answer to, and the question was, I have never had the flu. I've never had a flu shot because I've been afraid that the vaccine would activate my immune system and initiate a TTP episode. So what we tell patients is the same thing we tell patients with a history of TTP as well as other autoimmune diseases. And I think this, excuse me, this question arises from any immune-mediated disorder. And vaccines are obviously meant to stimulate your immune system to develop a response to prepare you to fight a pathogen, whether it be viral, bacterial. And there's always the concern, am I going to activate the immune system and lead to a relapse of TTP or ITP or many other conditions? And our answer is always the same, that the vaccine is important to help prevent infection, as we're seeing the importance now without a vaccine for coronavirus. You should get it. So in general, the benefits outweigh the risks. You should talk to your physicians about this and get a direct answer from your treating physician. But in general, just having TTP, ITP should not absolutely tell you not to get a vaccine. Vaccines can obviously be very important. And if we had one now, it might certainly lessen what's going on right now in the world with coronavirus. A good follow-up question to that was, I received the flu and pneumonia vaccines last year. What blood test should I ask my doctor to check to see if it helped? And with many vaccines, you can get titers done of the antibodies specific to each vaccine. So yes, you can do it. The question is, do you need to do it? It's debatable if you've not had infections. The bigger question is it something you do right now? No, it's not worth doing right now. But certainly, again, talk to your physician about that. But there are ways with many vaccines to really test your immunity to see if you've developed the immunity. This can be important if you got your vaccine while you may have been on steroids or Rituximab. It may not make the vaccines as effective. So you want to check with your physicians about that. Claire, before I go on too much further, any questions that are coming up that we should?
Yeah, we have several. Okay. The first one is, 12-year-old daughter is on COVID. Do you see any problems getting it? And additionally, she's had other types of coronavirus in the past, not necessarily COVID-19, but other types. Will that help her against potential COVID-19 outbreak?
Very good question. You have to be careful taking infectious disease advice from a hematologist. But in general, my understanding is an infection with a previous coronavirus does not generate immunity to this coronavirus. This is a different and distinct coronavirus. There's not right now a concern about an infection of the blood supply where many of these blood products like COVID are derived from. There should not be an issue with that. But certainly with a worldwide infection and supply chains that are being affected, it's certainly theoretically possible. I wouldn't anticipate that. But depending how long things go on, it potentially is an issue.
Are children with congenital TTP at higher risk for infection, and should they be concerned about contaminated plasma?
Yeah, I don't think the contaminated plasma is the issue. There are patients with congenital TTP who may be on just episodic treatment. And in theory, if you got a coronavirus infection, that would be enough likely to trigger an episode where you might require treatment. So I think watching the child for the same things you might look for, the petechiae that might be indicative of a low platelet count, would certainly be important.
If Quinine ends up being used as a treatment for corona, can a TTP patient in remission take the drug?
This was lower on the list, not that we weren't going to get to it, but let's get to it right now. And I'll ask Dr. George, who's done a lot of work with this, to chime in to see what he thinks. Excuse me. But this is an important question. I think the first way to start out by saying this, is we shouldn't be talking about specific treatments. And you need to consider the source when you hear treatment advice, what to do. Should I be running out and getting chloroquine or hydroxychloroquine, which are derivatives of quinine? In looking in the medical literature, I don't think there's the same connection between a hydrochloroquine and a chloroquine and the thrombocytopenia that you see with the quinine. But if we step back even further from that, and Dr. George has done a lot of work with this, looking at the quinine, and the quinine is probably the most common drug-induced cause of a thrombocytopenia. It can induce a low platelet count. It can induce a picture that clinically looks like TTP that may be more consistent with what we say an HUS TMA type picture. But quinine itself doesn't lead to an acquired or immune-mediated TTP type process. It can trigger some things that are similar. Now, that being said, drugs that are derived from that may not necessarily have that same effect. And I'm not sure if we know. There's certainly not a lot of reports of thrombocytopenia and those medications. So we have to take a couple of steps back here. And first of all, before we talk about any treatment, make sure it actually works. And just throwing medicines at a disease, a viral infection, is not the right way to go about this, and to be worried about that treatment right now without any really clear evidence that it works. And just as important, or more importantly, that it's safe. But even if that's shown that it works, that it's effective and it's safe, don't assume that we're going to see that same response with that we do with quinine. And also taking that step back, that what you see with quinine is not necessarily exactly the same thing as immune-mediated or acquired TTP.
So Dr. George just responded, and there was a request that you repeat what I say because they're not able to hear me very well. Dr. George responded, the quinine reaction is different from
Okay, so I'll repeat. Dr. George, thank you. He just let us know that the reaction with quinine is different than TTP, which is essentially what we've just been talking about. So again, that's still 3 steps beyond where we should be. But if it's ever proved to be effective, you shouldn't have any concerns about taking that medication.
So this question is, if as a TTP patient I'm in remission and didn't get coronavirus, what should I do? If I can repeat the question and then answer it.
Oh, sorry about that. Sorry about that. So if I am a TTP patient in remission and I get coronavirus, what should I do?
Is there anything different?
Really nothing different. You have to let your treating physicians know that you've been treated for TTP in the past. It might clue them in to pay more attention to that, to monitor your platelet count or your labs. But in terms of treatment, it's primarily supportive care. There's nothing different that should be done. There may be some monitoring that would be important of the labs, especially if you're being followed as an outpatient. Most patients are going to be at home, recovering at home with just supportive care.
And what would you recommend for the monitoring intervals for platelets and TS13 if they suspect they have a viral infection?
So the question was, what would we recommend for monitoring of the labs in the Adam TS13 if you suspect a coronavirus infection? So I think you have to remember that the platelet count, this LDH that we use to measure disease activity, is measuring what's going to happen today or tomorrow, or maybe more accurate, what's already happened. The Adam TS13 activity is more of the longer time frame. It's used to try to predict what patients may be at risk for weeks or months down the line. So in the short term, when you're being followed, it's really the platelet count. And the platelet count, the chemistry, CBC, a chemistry, and an LDH are really what's most important. Including your physician in that you've got a history of this makes the most sense. The Adam TS13 activity may be something to discuss with the hematologist, but it's not going to be urgently required and shouldn't hold up the routine labs that you probably need just for monitoring.
Are hematologists and nephrologists getting overwhelmed giving care to COVID patients such that TTP patients may be impacted for care? So make sure you read the question.
So are hematologists and nephrologists being overwhelmed where they're not able to care for TTP patients? And I think maybe the better question might be, excuse me. I'm okay, I'm just talking too much. The better question would be the whole hospital system. And I think that's what large hospital systems and states are really most worried about, the ability to handle a large number of coronavirus patients, but also the ability to handle the other things that come in, the heart disease, the cancer, the strokes, more rare, but certainly not insignificant, the patients with TTP. So I think it depends on where you are, it depends on the city and how many cases there are. There are certainly stories of hospitals getting quite busy in the New York, Washington, and in the Louisiana area. Not so much in Middle America yet, but that certainly could be coming as the wave of patients. But what you're seeing is hospitals start to really prepare for what happens, and what could be happening very soon. Shruti, I'll give you a couple minutes to chime in, but what's happening in Baltimore, since you're on the East Coast with a large population? What are you seeing in your hospital? So far, we've got a few numbers of cases in-house, nothing that's overwhelming the hospital system at this point. There was a question about Rituximab and using it to keep lupus symptoms at bay as well as helping to treat TTP. It kind of goes back to the point, we'll just talk briefly about this, that patients with one autoimmune disease are more likely to get another. And certainly we see that in patients who have TTP, as Dr. George has studied, will later develop other autoimmune diseases such as systemic lupus erythematosus, rheumatoid arthritis, and vice versa. Patients with autoimmune diseases may develop a TTP diagnosis. But again, the specific treatments really have to be talked about with your treating physician for each individual issue that you're dealing with, whether it's rheumatologic or in the nephrology world. So one size doesn't fit all. Don't look at your hematologist as treating these other disorders, even though the treatments may help the other conditions as well. It's really doctors working together to come up with a treatment plan that's most important. One other question, given the possibility of plasma shortages during the pandemic, should the healthcare workers with a history of TTP take additional precautions? So there's two important questions there. And the first one is patients with a history of TTP that are healthcare providers, and really the same things apply in terms of the risk and protecting themselves, hand washing, the social distancing, and the personal protective equipment that healthcare providers are using in the hospital. The issue of plasma, blood, other blood product shortages acutely is starting to arise, not so much because there's a run on blood products, but blood banks, Red Cross, and a lot of other blood providers rely on blood drives in order to replace this blood supply as it's used. And because of the social distancing, you're seeing less blood drives. They just can't happen. These large-sized blood drives are happening on a smaller scale. Here at Ohio State, we rely heavily on the students and the faculty as donors for the blood supply. And with people working at home and students no longer on campus, that's just not there. So it's not so much a demand on the blood supply. It's the ability to replenish it. The hope is that we'll get through this without draining the blood supply, but it should be replaced, maybe at a bit of a slower pace.
Okay, Shruti got back to us. She said, you'll have to repeat everything.
I will repeat what's, yeah.
We have several cases in-house and are maintaining our heme service. Preparing for large volumes of COVID patients and hematologists are being drafted to other services such as med services. We plan to maintain a fully staffed heme service as far as possible, and there's no concerns about running out of plasma as they have enough stockpile.
Thank you. So Shruti, Dr. Chad Reddy just answered in Declare and said they do have several cases. The hematology services are being maintained, but as is being seen there, you may see in other hospitals that hematology are being pulled into other specialties to help out, whether to care for coronavirus patients or to care for other diseases that might be out of their area to free up other physicians who then can be used to take care of coronavirus patients. So no issues at present in Baltimore, Maryland. But this is something every hospital's been preparing for and trying to prevent this rush on resources and beds, essentially.
And Dr. George indicated it's the same in Oklahoma, and Dr. Mascott said the same in Minnesota. They have a 300-bed COVID-only hospital, which opened today for Minnesota.
Okay. So from Oklahoma City and Minneapolis, Minnesota, where Marshall Mazep is, similar type of issues, getting ready for it, and Marshall indicated that they actually have a 300-bed coronavirus hospital that's been set up to sort of address these specific patients and as well isolate them, obviously. So thank you all for answering in.
There's a question if patients who have splenectomy are at greater risk to get COVID-19.
So splenectomy and viral infections is the question. And splenectomy is a topic unto itself that we'll talk about at some point in the future, I'm sure, on one of these USTMA webcasts. But the thought is it's encapsulated bacteria such as a pneumococcal, Haemophilus influenza are the biggest issues that splenectomized patients would face. It's not to say there may not be some contribution. On the surface, nothing excessive to be worried about. Would treat you just like anybody else in terms of isolation, hand washing, avoidance, things like that.
So does a lower than normal Adams TS13, so the 60% range, put them at greater risk for relapse or COVID?
That's a good question. So we have to sort of characterize what we mean by, I'm sorry, thanks, Claire. So the question was, does a lower than normal ADAM TS13 activity increase the risk for relapse of TTP as well as COVID infection, you said?
Yes.
Okay. So no real connection that we know of between low ADAM TS13 activity in viral infections. There's certainly, in most patients, well, if we step back, we use the ADAM TS13 activity, and I'll certainly ask Dr. George Chatterjee and Mazeppa to chime in as well. We use the ADAM TS13 activity to predict the risk of relapse. It's the best biomarker we've got to predict the risk in the near term of months. It's not perfect. So when the ADAM TS13 activity is undetectable or less than 10%, It does not mean relapse is going to happen. Patients have been followed for many years without a relapse with undetectable levels. That being said, we also know that when it is less than 10%, and many will now say 20%, there is an increased risk of relapse. But it's not like this risk absolutely begins at 20 and at 21 you're fine. There's still a lot to learn in terms of relapse of TTP, in terms of other cardiovascular, kidney, sort of hypertensive disorders that may be involved in this intermediately low range. We just don't know those answers, and research is ongoing with many others in our consortium to try to get some of those answers. So very good questions. We also presume that in many patients it's a slow drift down. Your ADAM-TS goes from normal down to 60, down to 40, down to 20, and then the relapse could occur. But there are certainly patients who don't follow that pattern and may just abruptly drop before you have the time to measure it or even act on it. So it's got to be put in a context. It is a risk factor. It's one thing that we use, but there's research ongoing with many sites as well as our consortium to try to improve that predictive ability.
What initially causes the drop in ADAM-TS13?
It's a good question. So the question was, I'm sorry, Claire's catching me. What causes the drop in ADAM-TS13? And the answer is we just don't know. For some reason, like other autoimmune diseases where you get antibodies formed against different tissues or cells, people can form antibodies against their own ADAM-TS13 protease. Why they do it, it's a good question. It's more common in females. It's more common in African Americans. But exactly why it happens isn't absolutely clear. And again, going back to the point of just because you're low, it doesn't mean you're going to develop TTP. I'm certain there are patients out there in the world that have undetectable levels of ADAM-TS13 that don't ever get into trouble. We see this with congenital TTP, where a woman can be born without or with very low levels of the ADAM-TS13, but yet won't have a first congenital TTP episode until she's pregnant and or delivers, which can be sort of that second hit that we've been talking about. So it's not absolutely clear why it happens.
What would you notice drop first, the platelets or the ADAM-TS13 if it was triggered by a viral infection?
Well, if it's triggered by anything, so it's the, oh, I'm sorry. I'm glad Claire's here to help me out. So the question is, what would you expect first, the platelet drop or the ADAM-TS13 if a virus or something else were going to trigger an acute TTP episode? So where we think the lead time is, it doesn't have to be this way, but we think typically it's the ADAM-TS13 activity drops, and that might place you at greater risk for the stress on your body that the viral infection could cause. If the ADAM-TS13 is low and it predicts a greater risk of relapse, it means days, weeks, months ahead of time, lead time, if you will. Once the platelet count drops, the process has started. There's no predicting it's already happening. So the activity in general should drop before we see the acute TTP episode, which is that drop in the platelet count. So between the drop in the platelet count and the low ADAM-TS13 activity is some time where things can happen, and that's really what's being studied right now as far as what's happening and what could be done to block that from progressing to an episode.
We touched on this earlier, but should health workers with a history of TTP avoid direct patient care during the height of the pandemic, and should we fear that there may be a shortage of plasma?
Again, we've talked, I'm sorry, I'm getting there. Should healthcare workers with a history of TTP not work with or be around patients who could potentially be infected with coronavirus? And another question about the blood supply. We'll go to the second one first. I think it's a quicker answer. There really shouldn't be a concern about the blood supply. There's a large enough blood supply. There's cooperation and collaboration between blood banks. I don't think that's going to be a real issue. This is not a disease process that typically is going to cause a run on the blood bank or the blood supply. In terms of healthcare workers, I think you have to view this like you would any other risk factor. In some institutions, patients with comorbid conditions or over the age of 60 are being pulled off of inpatient hospital services so they won't inadvertently be exposed because their risk is higher. That's going on here at Ohio State. So would just having a history of TTP automatically put you in that category? I don't think so. But a patient who's on immune suppressive medications for whatever reason, and we're dealing with this here, might be considered to be pulled off direct contact with patients, because not that their risk of infection is greater, but the risk of the downstream effects and the potential more serious complications in them is the main issue.
If there is a drop in Adam's TF13, how quickly would someone notice that?
So if there is a drop in the Adam TS13, how soon would you notice it? You might not notice it at all. And again, there are probably people, we know there are people in the world who don't have detectable Adam TS13, but who are completely asymptomatic. So you wouldn't notice anything. The symptoms you develop are the symptoms from TTP when you start to get the small vessels blocked by these small clots. So when you start getting symptoms, the episode's already happening. It's too late to stop it, if you will. So the drop is largely asymptomatic in the Adam TS13 activity.
Can there still be a TMA episode if the person's Adam's TF13 is normal and they're diagnosed with TTP?
So the question is, can there be a TMA episode if the patient or person's Adam TS13 activity is normal? And maybe this is a good time to is normal. So this is a good time to step back and do the terminology. And in the past, the term TTP, AHUS by Dr. George and others were sort of merged together, because whether you differentiated them, it didn't really change the treatment. It was just plasma alone. For patients with atypical AHUS, there is certainly a specific treatment that blocks complement activation. In TTP, it's targeting this antibody inhibitor. It's something called caplacizumab that blocks the formation of microthrombi. So as treatments have become more specific to each disorder, these have had to be differentiated. So the big term should be TMA, which is a pathologic term to describe small clots in the smallest blood vessels. It's also used in a clinical term to describe someone with a low platelet count and these schistocytes in their blood. But the TMA is the big term, the big overlapping sort of category. Underneath that, you have a lot of different forms of TMA. One is immune-mediated TTP, HUS, atypical HUS, congenital TTP. Excuse me. So the term TMA you can see a TMA in someone with a coronavirus infection, you can see it with an infection, you can see it with a diagnosis of cancer. So having a TMA does not mean you have TTP. Having a TMA means you have a process which may have led to clots in the smallest vessels, which manifests clinically as a low platelet count and fragmented cells. So the answer, that was a pretty long answer, I apologize. Yes, you can, but remember the TMA is not necessarily a diagnosis, it's a syndrome. Under that category, you have some specific diagnoses.
Further discussion on patients who are chronically deficient in Adam's TS13. If they aren't going into relapse and they aren't having issues, should they be concerned that they're deficient?
Yeah, so the question is, in patients who have undetectable Adam TS13 activity, who aren't having a relapse, who don't have other medical issues, should they be concerned? And I think maybe we take a quick step back. You're going to see more and more emphasis on the monitoring of Adam TS13 activity. And I'll certainly ask Dr. George, as well as Shruti and Marshall, to chime in on this. We're getting into a world where the monitoring of the Adam TS13 activity is becoming more and more important. With the newer treatments like caplacizumab, it's important to monitor, to confirm the disease essentially, initially, but also to monitor when you can stop and when you can safely stop this caplacizumab and other related conditions. It's a good tool to predict the risk of relapse. But right now, it's getting there. It's starting to get in mainstream clinical practice of hematologists who are more aware of the importance of it to predict relapse and maybe predict the development of some of these long-term complications. So we're still in the earliest time here of this monitoring. It's starting to increase for some good reasons, and I think it will continue to increase. That being said, this isn't the time to talk to your hematologist and call the office and get that test done right now. It's really not going to help you right now. It's something to discuss with your hematologist on that next visit that happens in the next couple of months, 2, 3, or 4 months down the line after this acute coronavirus issue has passed. So it's not going to help you right now. So I want you to be aware of this. It's certainly where the field is heading and has been heading, but it's not something to do right now. Your hematologist is not going to be excited about getting this ordered for you right now if they're being overwhelmed by other issues that need to be addressed as well.
Here's an interesting one too. There's been media coverage that plasma from patients who have healed from coronavirus can be used as a treatment for those currently infected. Should they then be concerned that plasma may be in short supply?
Oh, good question. So the question is, there's reports in the media of patients who have had the coronavirus infection and then developed the immunity, which is the antibodies. Essentially, they got vaccinated by getting the disease itself. This being a potential use for a treatment, is this going to impact the blood supply of plasma for TTP patients? And the answer is no. I mean, that's going to take some time. If you really think about what has to happen, you have to be able to readily identify patients. They have to recover from the severe infection and then be able to have antibodies harvested and processed for human use. So that may not be a short-term thing. That's also going to be very specific to coronavirus patients. So a patient with coronavirus is not going to get plasma. That's not likely to help. So this is something important for the future. Many sites, including our institution, are trying to study that acutely to try to help patients. But again, that's going to be a specific form of plasma from patients. And it's not just the plasma, it's the antibodies from their plasma. So that won't impact. That's different and distinct from the plasma supply for patients with TTP as well as other conditions that might require it. Another good question that came up, again, going back to the quinine, hydroxychloroquine, the chloroquine issue, again, there are questions, obviously, and could I get these if they work? Again, take that step back. If it is shown to be effective and safe, and I would also tell you there are a lot of treatments being studied. There are other antiviral treatments that have been, the question have been raised by questions posed in this form that are very good, but there are multiple groups around the world working hard to try to identify treatments for this. And I think the chloroquine and the hydroxychloroquine are just one that got recent press from the discussion in our country. But there are multiple avenues, so there may be other treatments available potentially. So don't necessarily focus on just these and your need to be treated, I would tell you.
How long after Rituximab is your immune system weaker?
So the question is, how long after Rituximab is your immune system weaker? Now, I guess I would start out by saying, and again, I'd ask my colleagues to chime in, we don't necessarily view, this is certainly decreasing, it works by the Rituximab binding to your B cells and clearing a large proportion of your B cells. And the B cells are what make the antibodies that go against the ADAM-TS13 as well as other things, which is why it can be helpful in many autoimmune diseases. It's certainly not clear that there's an absolute increased risk of infection. There's certainly concern for reactivation of previous viral infections like hepatitis B, the thought that there may be an increased risk for sinus and pulmonary infections, bacterial infections. It's not thought that the immunoglobulin levels go completely low to the levels where you're like a patient with an inherited deficiency of those. So to say when I am not or am immune compromised, it's not absolutely clear how immune compromised you are. That's why the safe way is to say that assume that you may be and be extra careful. When that time period ends, it's really hard to say with any certainty.
Here's a little different topic. What is the likelihood that one who has TTP would flare up when they get pregnant, and how can one assess that risk?
It's a good question. It's a little bit different, obviously, than the coronavirus questions. But we've been talking about this second hit. And the second hit can be the coronavirus in a susceptible patient. It can be an infection. It can also be pregnancy. So a lot is being learned from investigators in our consortium as well as investigators around the world. And Marie Scully has done a lot of work with this in London. But it's certainly the opinion is growing that if you have low ADAM-TS13 activity, pregnancy can trigger an acute TTP episode, which can be quite dangerous to mom and the unborn child. A lot of effort to monitor carefully patients who are pregnant with a prior history of TTP and their ADAM-TS13 activity, with the potential to intervene to improve this activity, either before the pregnancy or during it as well. Excuse me. Make sure we caught all the questions here. And some very good questions. I would also caution you that the answers that we give you today could change in the next weeks or month as we learn more about this infection as well as TTP. Important thing. Go ahead, I'm sorry.
This patient lives in a country where ADAM-TS13 testing is not available. How essential is ADAM-TS13 testing to a treatment protocol, and what would you recommend in its absence?
Good question. So in someone who lives in a country where they don't have ready access to the ADAM-TS13 testing, what is the impact on this, on their treatment? The main impact on the ADAM-TS13 activity, and I hope that this testing gets more widespread. It is starting to happen. We're seeing it in many countries around the world. But it's certainly not having the ADAM-TS13 activity. And I've heard from colleagues around the world where the testing is still able to be done, but not necessarily in real time in a couple of days. It may take a couple of weeks to come back. So it may be done, but not during that first week or two of the hospitalization. It's very useful in cases of a new diagnosis to really confirm that this is an immune-mediated or acquired TTP case. Excuse me, I'm talking too much. It's important for the prediction of future relapses, but that may not be available. It's certainly important up front to really confirm this clinical diagnosis. But it won't change your treatment. It won't change the upfront treatment of steroids, plasma exchange, and possibly Rituximab as well.
Said, my take is that low ADAM-TS13 puts them at risk for TTP, but immunosuppression puts them at risk for severe COVID. We can easily treat the TTP patients when we know their symptoms, so my take is that observation is still probably better, risk/benefit, but that decision should be individualized. Still doing their best to social distance and avoid unnecessary exposures, of course.
Thank you, Marshall. So Marshall just chimed in, and certainly I think you put the whole thing into a nice perspective. The ADAM-TS13 activity, when it's low, puts you at greater risk for a relapse of TTP, but immune suppressive treatment will certainly increase your risk of coronavirus infection and complications from it. So really, it's the same recommendations that we would say to other patients, the same cautions of hand washing, isolation. This is certainly not the time. The discussions of immune suppressive treatment to predict relapses of TTP is certainly an important one, but I think Marshall put it in the right context. It's not the important discussion to have right now. Any benefit you might get from that's going to be down the line. And doing something right now is really not a good choice. We've talked about steroids a lot. They're a very important part of the upfront treatment, but they really should not be continued long term because of the side effects or the potential side effects. And the longer you're on them, the greater number and severity of side effects you could have.
There's further questions about if you have low ADAM-TS13, how do you not relapse?
So it's certainly a good question. So, and you have to be careful in looking at this. But the question is how, if your ADAM-TS13 activity is low, how do you not relapse? Is that the question? Did I get that correctly? Okay. So you certainly have to understand how we do this. And most of what we've done in research studies is looking retrospectively. So it's following patients and looking back on what happened to them. So when they had their ADAM-TS13 activity checked 5 years ago, what happened after that? And it's from studies like that and from serial measurements every 3 months, every 6 months in some institutions. We, as well as many of our sister institutions in the consortium, have been involved in doing collaborative research, trying to have a tissue bank with clinical data as well as lab samples so we can go back and learn. So a study that we did here at Ohio State now, maybe it was back in 2009, looked at this exact thing and looked back and said, whoever had the ADAM-TS13 activity drawn, who relapsed in the 3 months that followed. And then when 3 months later passed, they had it drawn again. And what we found that when it was less than 10%, if you took everybody who was less than 10%, the risk of relapse over the next 3 months was not that high. It was approaching 10%. But one thing we learned from that study is if you broke this down into different age groups, the younger you were and the ADAM-TS13 activity was less than 10%, the greater that risk was. The highest risk was in the patients who were the youngest, in the 20 to 30 age group, with undetectable activity, but still it only approached 35 to 40% of a relapse in the next 3 months. So the best way to answer that question is the ADAM-TS13 is an important risk factor, but I think we're starting to learn it's not the only risk factor. And there are other parts of the immune system that are being studied. There are things such as race. There's some work ongoing with our consortium now looking at different racial effects. So African Americans, Caucasians, other races, where the risk of relapse may be increased or decreased independent of the ADAM-TS13 activity. I think where we're headed in the future is multiple risk factors being put together in a model to better predict the risk of relapse. The ADAM-TS activity is good. It's not the only thing, and we're working on other factors to add into this to help model, if you will, what that risk of relapse is to improve it upon just the ADAM-TS alone.
So Dr. George and Dr. Shruti wrote in, and they agree with Marshall that the patient isn't isn't on preemptive rituximab. They wouldn't start doing anything new.
So Shruti Chatverdi from Baltimore and Dr. George chimed in and agreed with Marshall and myself that certainly all these issues are important, but not right now. Starting a treatment protocol now to preemptive therapy to prevent relapse by improving the ADAM-TS13 activity might make sense in the future with discussions with your physician, but this is certainly not the time to do it.
In addition, Dr. George wrote in and said that a great example, the answer is illustrated by hereditary TTP. These patients have no ADAM-TS13 for years, even decades, and they can have no symptoms.
Excellent. So Dr. George just answered and really echoed what we said earlier about congenital TTP. And when we talk about animal models of TTP, you can think of congenital TTP as being the human model of TTP, where people may be born without ADAM-TS13 activity, but don't get in trouble until age 25 when they get pregnant and they get that second hit. So it's just the ADAM-TS deficiency has always been there. It took something else on top of that to do it. Thank you, Dr. George. We've got about 5 minutes left in our webcast. Maybe we can go a bit over. I'm not sure how long my voice is going to go. And I would certainly let you know that we may be more limited on time here, but certainly keep the questions coming, and we'll get them addressed between myself and Dr. Mazeppa and Dr. Chatverdi and Dr. George as well, and maybe even post them on the consortium website.
Here's an interesting question that should be shorter. Is there a chance that a sibling of a ITTP patient could have a greater risk of being diagnosed with ITTP themselves just for being related to a patient with TTP? Not the hereditary.
Good question. So is there a family inheritance of the immune-mediated TTP? So it's an excellent question. We don't think you inherit immune-mediated or the acquired TTP. But is there something about your bloodline that might make you more likely to develop autoimmune diseases in general? Excuse me. That's certainly possible. But inheriting immune-mediated TTP is not something that we typically see.
Is there any correlation between the new experimental treatment for sickle cell, which shows promise, and using it for similar treatments of TTP? I'm not sure what the exact is, but the other question is, how far do you think we are from a cure?
questions. So two questions are some of the advances going on in sickle cell and some of the small molecules that are being studied in sickle cell disease to decrease pain crises and other manifestations of the disease. Are they applicable to TTP? It may seem that sickle cell and TTP are certainly completely different disorders and not overlapping at all. But when you look at them both long term, they're both very similar in terms of small vessel issues that patients can experience and some of the long-term issues that you might see. So there are certainly studies ongoing that are overlapping into both worlds, sickle cell into TTP and vice versa. And one good example is the ongoing study of the recombinant ADAM-TS13 activity in congenital TTP that's ongoing now in multiple centers across the world. It's also being studied in sickle cell disease. So the answer is yes, there may be some applicable things in both disorders, that what you learn in one might help the other. And what was the second part that I can't remember now?
How close are we to a cure?
Oh, how close are we to a cure? You know, in immune-mediated, it's hard to say. So one thing that we know is a patient can get TTP at the age of 20 and may never get it again. They may also develop multiple relapses. And at this point, it's hard to tell them apart. We think most patients, when they relapse from immune-mediated TTP, may do so in the first year especially. But that doesn't mean 5 years out it can't happen again. So right now our knowledge doesn't let us accurately predict who's cured and who may get this again, who may be at risk for it again. It's a good question. It's what we're all working on.
Are there certain immunosuppressants that have a higher risk of catching respiratory infections than others?
So the question is, are there certain immune suppressants that place you at higher risk of getting respiratory infections, I guess bacterial as well as viral? And I think there are a large number of immune suppressive treatments out there. One, certainly, that are used in TTP targeting this ADAM-TS13 antibody. So I would tell you each specific treatment may have its own specific set of complications and cautions. Any treatment you look at, you're going to see how effective it is and what are the side effects, what are you paying for in terms of that efficacy, what are the risks. It can be different for each treatment, so you can't presume one and the same for all of them. So that's really an individualized discussion with your physician.
Quinine has been noted to be in tonic water that's suggested to avoid with patients for TTP, correct? What about other foods such as bitter nut or fruit?
So we talked about this a little bit earlier. The quinine causes a distinct entity from TTP. So if somebody with a history of TTP would like to take gin and tonic, shouldn't be an issue, shouldn't be a problem. Different, again, falling under that TMA category, but different distinct disorders. And while Claire comes up with this, I'm going to put in a shameless plug for our USTMA, the first annual National Patient Group meeting that's going to be happening, we anticipate still in August in Chapel Hill, North Carolina, August 21st through 23rd. It's a beautiful venue. We hope you can all make it. More information is on the USTMA Consortium site.
Is Caplicizumab now the best treatment for an acute episode of TTP?
Very good question. So is Caplicizumab the best treatment for TTP? Best is kind of a loaded term, but it's certainly the first FDA-approved treatment. And it's a very effective treatment. It is part of the treatment of acute TTP, and I think should be a major part of it. But again, that depends on other patient-specific factors. It works by not altering the disease or the antibody, but it blocks the formation of those small clots that give you the low platelet count and the fragmented cells and the injury to the kidney and the heart and the brain. But what it does in blocking the formation of those clots also impairs your body's ability to clot your blood. So you're trading off a prothrombotic disorder for a mild bleeding tendency, which is quite manageable. So is it an excellent treatment? Yes. But you got to talk to your physician to balance the risks and benefits as you would with any other treatment. Now, as long as my voice goes, I'll go.
Okay. So here's a good question. After an initial TTP episode, when the patients recover, how long do you suggest as TS13 monitoring?
So it certainly depends on the center. I'm sorry, I got right to it again. Sorry, Claire. So the question is, after a TTP episode, how should the ADAM-TS be monitored? How frequently should it be monitored? I'll ask my sort of co-contributors here to chime in as well. It's an increasing activity. I think it's an important part of the monitoring of patients in remission to both predict the risk of relapse, but it may also, not yet, but it may predict the risk better of some long-term complications that we've discussed previously, some cardiovascular issues potentially. So there's no one set answer. Our experience has been to monitor patients every 3 to 6 months. We've been doing this now for over 10 years. It's a back and forth between the patient and the physician, the benefit you get from monitoring, and the counseling that has to go with it to not make people anxious unnecessarily. So there has to be more than just ordering the test and handing it to the patient. The physician really has to be comfortable with how to handle this test in the context of that patient and their disease. So again, a good discussion to have with your physician. I think you'll have more of these discussions in the next couple of years, months maybe, as this becomes more of a relevant issue for patients and part of the regular follow-up.
So Dr. George chimed in and said it's obviously too soon to say that Caplicizumab is the best, but it is the fastest path for a response. That's for Caplicizumab. And then he also chimed in and said, annually forever seems like an appropriate time to get IMCS-13 drawn for a TTP patient.
Very good. So Dr. George said certainly Caplicizumab is a very good treatment to shorten a TTP episode, which is what you see from the published data. It's a quicker time to achieve a normal platelet count, but too soon to say it's the best treatment, which I would certainly agree with. Their practice is annual monitoring in Oklahoma, I think, for the ADAM-TS13 activity. And I would certainly agree. I'm sorry, for life. The monitoring is a function of certainly how easy they can get to your clinic and a balance of those factors. So the hope is that testing is more readily available. There is more testing. There is easier access to testing. And I think as research hopefully shows an impact, whatever that may be, predicting the risk of relapse or other things, then ready access to testing is available. It doesn't help if you can use a test to predict something if patients can't easily get it. So that's something that's being worked on as well.
Chimed in, she says, it depends on whether you plan to do anything about the activity. If there is a plan to use preemptive Rituximab, she checks every 3 months. If there is no plan, then I try to restrict it to research only since it's not acted on clinically. And for those who have not relapsed in years, she spaces it out to annually.
Very good. So Dr. Chattaverty answered, and certainly it's a very good statement. So it depends what you're going to do with it. If you're going to use it to act on it, meaning if you believe the data about using Rituximab or other immunosuppressive medications to prevent relapses, then certainly it makes sense. If you're of the opinion that it's not going to be used in that way, it may not be so useful to test it. And Shruti also said in patients who are long out of the most recent relapse, if I'm quoting her correctly, they'll monitor annually as well in some of those patients. So again, you're seeing it's multiple different physicians with slightly different approaches to it, the same sort of concept, but also it's pulling in the patient as well and what they're able to do, both getting to the clinic, how much trouble it is to get the testing, as well as their understanding of it and what they're going to do with it, and not be overly overwhelmed by anxiety from it.
Here's a question about Caplicizumab. The question is, Caplicizumab is really just buying you time, though, and due to its mode of administration, it needs to be given quickly, correct?
Well, the question is Caplicizumab, it's sort of just buying you time, and because of its mode of administration, it needs to be given quickly. I think if we go back again to say what it does, it blocks the formation of those clots. It doesn't fix the ADAM-TS deficiency that occurred in most cases by your immune system doing it, but it blocks the downstream effects. So in general, the sooner you have the diagnosis, the sooner the drug should be administered. It will work better the sooner you give it. But it brings up an important point. This doesn't fix the underlying disease. You can't just give this treatment for 2 weeks, stop it, and assume things are going to go well. If If you look at the studies, there were certainly patients who relapsed after the Caplicizumab was stopped. It's sort of a temporizing measure, if you will, not absolutely the same, but similar to plasma exchange, where you're removing the antibody, adding back ADAMTS13 protease, but you still treat them with steroids and rituximab. So think of it sort of similar, if you will, to the plasma-based therapy.
Dr. Mascon wrote in, and he said, I generally recommend close monitoring for the first year until they have a better handle on whether the patient is going to have frequent episodes, and then decide together how often to monitor. Ideally, everyone would go on a research protocol for more frequent monitoring to help sort out the best candidate.
Excellent. So Marshall Mazeppa sort of said initially they'll monitor people more frequently, maybe every 3 months, every 6 months, maybe space this out, but ideally, and I would agree, certainly patients who are doing this it should be done if possible on a research protocol where we can learn from this, both to help other patients as well as that particular patient. And which is also, I'll put in a plug for our consortium. It's one of the benefits is allowing people to identify sites close by to them around the country that they can get both good information on TTP, but also access to research studies to be able to participate. The only way to learn more is to really study patients with rare diseases in a standardized way to know what's happening. What we're talking about now is really a function of what people, including Dr. George, have done going back into the 1990s and early 2000s. So it's the only way to learn more.
And again, just to reiterate, does a TTP patient have a greater risk or concern of getting coronavirus than a typical healthy person?
Good question. So we're back full circle, which is good. Does a patient with TTP or a history of it have a greater risk of a coronavirus infection? And the answer is no. Outside of those rare instances where they might be on an immune suppressive treatment, there's really no difference. And everything you're hearing from your local authorities applies to patients with a history of TTP. It's the social distancing, the hand washing, the avoiding of known people, and if you were infected yourself, isolating yourself and talking to your own physician, but nothing about you that makes you any different than anybody else.
How long does rituximab remain effective? And how long is a patient considered immunosuppressed because of rituximab?
Excuse me. So the question is, how long does rituximab last, and how long should you be considered, immune suppressed? We sort of touched on those a little bit. In general, patients who get rituximab, the B cells that are knocked down will come back in 9 to 12 months, but that doesn't mean that the antibody is going to come back. So the hope is, and there are some patients who may be, if you will, cured by the rituximab. It knocks out those B cells that were producing the problem. But that doesn't mean it's going to happen or we expect it to happen. You could regenerate those same B cells that will then produce that same antibody. How long that occurs, it's variable from patient to patient. It can be 10 to 12 months. We've also had patients go much longer before they develop a recurrence of their antibody that clears the ADAMTS13 activity, somewhere in the range of 3 or 4 or 5 years sometimes.
Does a pre-existing viral condition, and this may be more of an infection disease question, does a pre-existing viral infection such as a low-grade cold increase the risk of catching coronavirus?
You better consider your source, and I'm a hematologist, but in general, no. I mean, your body can be weakened by anything, including a previous infection. I'm sorry. We got a bad problem here. So does a previous or ongoing viral infection impair your ability to fight or stave off a coronavirus infection? And my first comment is, as you heard me say, is consider the source and don't take infectious disease advice from a hematologist. But in general, anything that could weaken your body, previous infection, illness, might make you have more difficulty fighting off a coronavirus infection or anything else. But nothing specific about that and nothing to hang your hat on.
Do you think, or are there studies going on to help figure out what causes acquired TTP? So, causes the antibodies to be built up?
So are there studies going to know what causes TTP? And that's certainly a tough question to answer. We know from previous work done by a lot of people that we know who's more likely to get it. It tends to be females, again, more than males, African Americans more than other races. But what causes it to occur is hard to say. I mean, it's still a rare disease. And it's certainly hard to study thousands and, if you will, millions of people in order to pick up a small number who will get this disease in the future. So we're forced to look backwards and find things that may predict it. But it's very difficult. It's sort of a perfect storm, if you will, of where this happens.
This is a good general question. How can a patient who's interested in being part of a research study become part of one?
Question, so how can a patient who is interested in being part of a research study become part of one? And that's a very good question. It's in part why we sort of formed this consortium to let access. Well, it works both ways. It allows us to more effectively accrue patients to studies to learn more, but it also brings the studies and the physicians with expertise in TTP sort of closer to you, if you will, so you can find them. So I would tell you to keep track of the USTMA site where we identify the different institutions that really span not the far west, we're trying to get there, the sort of the deep Midwest, the plains, north, south, and east, multiple centers that you might be able to find a center nearby you and see one of our investigators that might be able to help out. All research studies that we open as a consortium, we tend to open in multiple sites. So there's a pretty good chance research studies that our consortium is doing should be at a site that's not too distant from you.
Do they test plasma for coronavirus?
All blood products are, I'm sorry, I got a problem here today. So, no, I'm okay, I got enough. Thank you. So Claire said the question was, is plasma or blood products tested for coronavirus? The blood products are tested across the board for every sort of pathogen that can be tested for. Unfortunately, we can't accurately test and reliably and a large number test patients right now. So the blood supply is certainly not going to get tested until we can accurately test patients. But I don't think most of the existing blood supply has been banked in the past, likely prior to this outbreak. So it should not be a huge issue. And it's not likely to be a problem. We won't know that for sure until we learn more. But I think the blood supply is not routinely tested, I don't believe, for influenza or things like that. More for pathogens which can cause long-term problems like hepatitis C, HIV, and other viral infections. Don't believe it's routinely tested for influenza and seasonal viruses. But Dr. George, Marshall, or Shruti, if you have any questions or comments, please do.
What percentage of people have an episode of TTP will eventually relapse? Is there a typical time to relapse?
So what percent of people with TTP will relapse, and is there a time to relapse? I think the best number might be a 50-50 shot, meaning if you've had TTP, there's about a 40 to 50% chance you'll relapse it sometime in the future. It may be more likely to happen in the first year, maybe the first 24 months. It's hard to know exactly, and I don't think you can say when that risk is down to zero, when you're not going to relapse.
How are the trials for the new treatment for congenital TTP going, and when do you think they will be available to the market?
So the question is, how are the trials going for congenital TTP going, and when are they going to be available? Very good question. So the trials are ongoing in multiple centers. They're ongoing here at Ohio State. And what it is a recombinant. So it's an ADAM-TS13 protease that's made in a lab that's infused to patients. It's actually being studied for both congenital and the immune-mediated TTP. When they're going to be available, it's going to be years. It's going to be 1 or 2 years. Hopefully not longer, but it could be. It's really a function of how long it takes to get the patients enrolled, how effective it is, how safe they are. And those are things that you're seeing brought into focus now with the coronavirus. And they're trying to get trials rapidly open to study to learn more, at least the initial answers. Is there a benefit to these patients? But truly, it's unfortunate, but it's true. The good science and clinical research takes some time to get the right answer. You short-circuit a lot of things for the acute issues like this. But for questions like that, there's going to be more time involved to know for sure. Marshall, you can answer better that. I forgot Marshall is a blood banker actually by training as well. So he might be able to help out with the viral pathogens. I don't believe they're tested for, though.
Dr. George wrote it. It said the relapse is closer to 20% after the use of Rituximab.
So Dr. George just messaged in The relapse is 20% after rituximab, and I'm not sure we're talking about certainly the after the treatment. It sort of certainly delays. I think most people in some of the work that we just presented at the hematology meetings from our consortium certainly suggest that, and Marshall can chime in as well, that in general delaying relapse, not necessarily curing people, I think is the idea. But that's a good question. When more and more people are being treated with rituximab, the question is, are we curing people or are we just sort of delaying relapse by 2 or 3 years where you may have to keep doing this? That's really the question. I think the initial data say we're pushing it, we're kicking the can down the road, we're delaying relapse, not necessarily curing people. But that's not known with any certainty either.
How important is a person, how important is it for a person in remission from TTP to deal with a doctor who understands coronavirus but has no understanding of TTP?
So the question is, how important is it for a patient with TTP to deal with a physician that's well-versed and understands coronavirus?
Yeah, so a patient, they're in remission, and they're dealing with a doctor who understands coronavirus but not necessarily TTP. I assume this is for a coronavirus-affected person.
That's true. I think what you're going to see is if someone who has developed a coronavirus infection, they might tell their physician it's true that they've got a history of TTP, and then they may, I would assume, get the assistance of a hematologist or be able to just look at their blood and say a normal platelet count. The LDH may not be increased, or if it is increased, what could it be due from? So if someone's sick enough to be in the hospital, certainly a hematologist could see them. So this is going to be sort of multi-specialty care for the sicker patients especially.
Is plasmapheresis processed to filter and neutralize viruses before exchange?
Plasma is, sorry, Claire asked the question was, is plasma processed to minimize pathogens, viral infections? And the certain answer is yes. It's to the best of the ability that you have, that it's tested for viral infections. Things are inactivated and made as safe as possible. It's not so common here in the U.S., but there is a form of plasma that's solvent detergent treated that attacks many pathogens. It's a bit more expensive. It's not used as much in the U.S. as it is in Europe, and especially the United Kingdom. But certainly there are screening methods, whether it's questions, there's testing, and again, it can be treated, solvent detergent treated plasma as well. Excellent questions. Claire had suggested this as we started to realize our typical group meeting that we have scheduled for early May sort of may not happen with these sort of travel issues and get-togethers being restricted. But certainly raised the question of this need, and your questions coming in sort of highlighted that. So I think our idea was we'll commit to continuing to do these every 2 or 3 weeks as the demand allows. We'll certainly be available for questions. Dr. George, Mazeppa, Chaturvedi, and myself will all be able to answer questions. As you've been saying them, keep them coming into the consortium, and we'll answer them as quickly as possible to try to give you a good answer.
We got one last question.
One last question.
If rituximab is used as a preventative measure for relapse, how many times can an individual receive rituximab?
Good question. So if rituximab is a good preventative medication to prevent relapse, how often can it be given? And it's certainly not a perfect medication. It works for the majority of patients. There are some patients where it may not be as effective. But in general, if someone's responding to it, we think they should be continually able to get it. I think, it's been around longer for lymphoma than it has TTP, but probably close to 20 years it's been around. And there may be some patients who have been treated ongoing for nearly close to that time. So the idea is that if it's working, it likely will continue to work. Certainly no guarantees, but that would be the idea. Well, thank you all very much for your attention. Thank you, Claire, for the help with this. And email any further questions you have to what you see on the screen, the admin at ustmaconsortium.com. Check out the information on the group meeting this summer. And I also want to thank Dr. George, Dr. Mazeppa, and Chad Reddy for helping out with this as well. Well, thank you all very much. Be careful and be safe, and we'll talk to you again soon.